you our speaker today. And this is none other than Nyarambe Wigina. And Nyarambe Wigina is an accomplished medical lab professional who has a diploma in medical lab technology. He has done her diploma. He has done a bachelor's degree in medical lab sciences, and also has a master's degree with a specialization in hematology and blood transfusion. Mr. Wigina is currently the chairperson of the Department of Medical Lab Science, School of Medicine and Health Sciences at the Technical University of Mombasa. And he's also a member of the Technical University of Mombasa Scientific and Ethics Review Committee. And we are privileged to have him as our speaker. He's also an internationally recognized scholar who is an active member of the International Society for Blood Transfusion, that is ISBT, and also serves in the Blood Donor and Donations Working Party. So Mr. Wigina is, of course, a registered medical lab officer of good standing with KMLTB, and he has passion to empower medical lab officers to the greatest heights. And currently, I know that he's venturing a lot into the AI space to open up new frontiers for our cadre. So, Mr. Wigina, if you can hear me, we are privileged to have you. We are excited to join into this presentation. And you can say hi, and you can proceed.
Thank you, Arthur. Thank you very much. I hope you can hear me. I'm audible, Arthur?
Yes.
Thank you. So good afternoon, colleagues, and welcome to this webinar. This is my very first time to present at LMSK webinars, so I'm grateful for the privilege. And I have been teaching for some time, and I've also practiced. And one of the things that amazes me is our ability or inability to not take into consideration what we learn and not further what we learn. And this is an important aspect because, as we know, medicine as a profession depends on medical laboratory sciences and services as the eye of the profession. So at any one time when we do not venture into our space and make sure that we take everything on board and do, then sometimes it's not a very good thing, meaning we do not give the services that are required. And that is why I decided probably, and LMSK gave me the opportunity to look at antibody identification, so that if wherever we are touched, then we can start doing antibody screening and antibody identification, because this is something that we know is supposed to be happening. So with that, then probably I could say that antibody identification matters. Why? Because antibody identification helps us to prevent hemolytic transfusion reactions. It also helps us to prevent or mitigate the issues arising from hemolytic disease of the newborn. Now, antibody identification will therefore help to support transfusion through accurate antibody detection. And here, when we are talking about antibody detection, we are focusing mainly on the fact that at any one time, you can have a HTR, but the HTR is definitely affecting so many other areas, including renal, oncology, and antenatal patients. And here we find that people who have been multi-transfused actually require us to identify the antibodies. And these people include people in renal, people in oncology, people in the antenatal patients, because they have been sensitized. Most of them have been sensitized. Someone, a mother, a multiparent mother, has been sensitized, and therefore, at any one time, she may need their antibodies to be quantified, detected, and quantified. And this is very, very important. You also need to know that actually, when you do antibody identification, we improve cross-match safety, and therefore the transfusion outcome is also improved. So anytime that we have a reaction or anytime we have a cross-match that is incompatible, why not venture into antibody identification? So it means that we as laboratorians will therefore cement the serological expertise so that we can look at what is critically, what the critical phase of medicine, okay? And despite the automation, we still are very relevant. So this is where you are, or we are very relevant in that we need to make sure that we know that the antibody identification is done. So that is critical. So as we go, we automate, remember, as you automate the cross-match, you need to now go further because now you have automated the cross-match, but you need to set up those 15 tubes that you can use, or 18 tubes that you can use for antibody identification. Okay, so there are many blood group systems, okay? And these blood group systems definitely will, one time or another, be culprits in antibody screen, positive antibody screens. And therefore, we will suspect an antibody problem when a cross-match is incompatible despite a correct matching. So it is matching, but it is incompatible. And most of the time, this is back to basics. You need to, you can get an unexpected reactivity either at room temperature, that is when you do the instant spin, or at 37 degrees centigrade, or with the AHG tube. So with this, then you can be able to now say, oh, okay, there's an antibody problem. So when you have a positive direct antiglobulin test and clinical symptoms of hemolysis, then you know, sure, here there is an antibody problem. And of course, sometimes you have not gotten these signs, but your patient has unexplained post-transfusion anemia. So when your patient comes back, the HB has gone down, they are anemic in all ways, then you can suspect an antibody problem. And in our setup, sometimes these patients don't even come back. So, but when they come, they go maybe to another clinic or another area. So when you are in that clinic, in that other area, you must have a history. And this is what we always say, key. When somebody comes to the hospital, when a clinician writes a request, make sure that you use the proper request form. And henceforth, you have including the patient's history. With that history, then you can be able to suspect antibody problem, or that the patient actually was transfused and therefore would have had an antigen problem. So, is there an antibody or is it not there? Well, how do you do this? We do this by doing an antibody screen. Basically, an antibody screen is where you use a panel of cells, a few cells, and with as many antigens as possible to capture whether or not there is an antibody. And these usually, most of them are usually IgG antibodies that we have that cause a HTR, or that will cause hemolytic disease of the fetus and the newborn. Usually we use O cells. Most of the time for screen or screen cells, we use blood group O, the ABO blood group O cells, and we know we have the antigen phenotypes already done. And then, of course, the same way we do our DAT or IAT, that is direct antiglobulin test or indirect antiglobulin test, we have to have our 3 or 4 phases. So the instant spin phase, that is so that we can check whether or not we have the cold antibodies, that is the IgM. The warm, so that we know whether we have high amplitude IgM or complete IgG, and then the AHG, which are the incomplete and blocking antibodies. So these ones we also detected there. So the antibody screening detects the unexpected alloantibodies. Okay, the screen detects whether or not, that is there an antibody or is it not there? And basically that is what we do, so that we know whether there's when there is agglutination, of course, there is incompatibility, and therefore there is an antibody that now we need to test for. Okay, so now the screen panel, can be supplied, or you can develop, and especially this one, I would call upon our colleagues at the RBTCs and the NBTS to help us out so that they can also make for us these panel cells. So these panel cells can be made or can be acquired. And when we acquire these, then they are able to help us. Now, the panel cells will have a defined set of antigens, and with this, you can have either 2 sets or 3 sets. Here I'm having 2 sets. We have the R1. This is capital C, capital C, small e, and panel 2 is capital. This is RH. So RH capital small c, capital E, that is the second one. So when you have now this panel of cells, then you are able to, these cells, the antigen that is listed here, for example, the RH, all these cells, that is the column, sorry, the row for cells, all these are the ones that are available in the panel that has been given there. So for panel 1, they have the antigen D, antigen C, small e, the antigen M, antigen N, antigen S, antigen Lewis A, antigen Lutheran B, and antigen Kell, antigen Celano, antigen Duffy A, antigen Kid A, and antigen Kid B. So when you acquire this is what you're going to have. So when you have this now, you use this panel to do a DAT on your serum. So you take your serum and so you do an IAT. You take your serum, react with cells from this panel, and if there's a reaction, then you know one of these positive cells here, one of these positive antigens here is actually present. If it doesn't react with any of this, then you know none of this is present in your serum. So your serum had a reaction and an incompatibility, but when you use panel 1, there was no reaction. So you probably, that is why you use 2 or 3 panels with differing antigens so that you are able to now detect whether or not there is an antibody. Now, if you do not get, probably you have an autoantibody of sorts. So that is an important element of the first steps, the initial stages of antibody identification, where you do the antibody screening. So these are panels that you use for antibody screening. So the panels will vary with diversity, and the diversity is what now increases or improves our accuracy when you are now going to do our screen and our antibody identification. Okay, now, so it is important to understand that from doing the screen, you will go and do the antibody identification. Now, identification is important, and it is a sequential systematic activity that us as laboratorians are supposed to carry out. So it is important, therefore, that we are able to understand that in this, we need to have guidance on whether there's a strong reaction or a weak reaction. So you need to have a reactivity pattern. So when you have a reactivity pattern, so that you know when the clot is massive, then probably you score it as 4+. When they have diffuse tiny clots that you can only see microscopically, then you probably label that as either weak positive or 1 positive. So that is important when you are doing antibody identification. So also that when you are doing antibody identification, you must check for consistency, whereby the reaction produces reproducible patterns, so that if you have panel of cells, for example, we have here 9 panel cells, so 9 panels of cells. If you check and you find that an antigen, for example, antigen D, is reactive with your serum, but in panel 2, but it is not reactive in panel 3, and both these 2 panels have the D, then you know there's no consistency. So it is important for us to actually check whether or not our results are producing reproducible patterns. Next is we need to map the pattern against the profile. So it means, therefore, that if you have reacting antibody, the antibody is reacting well with the antigen, and the pattern of results is reproducible, then you need to check, where is this reaction? Is it at IS? If it is at IS, that is instant spin, you know that should be an IgM antibody. It's a cold antibody. So if then you check that the reaction is at IS, but the antibody is normally an IgG incomplete or blocking antibody, then you know the profile is not matching. And therefore, that is a clue to check whether or not the antibody identification is working for us. Then finally, we also need to check for mixed antibodies, so that when there is reactivity at room temperature, that is instant spin, or at AHD. So you need to now differentiate how is it that there are. So we need to now understand, how do we now check for whether or not which antibodies are these? Are they 2 antibodies? Is it 1 antibody? So that is very key. So for us to do an antibody identification, basically we need to confirm the reaction phase. In confirming the reaction phase, we need to understand or check for the reactivity. For example, we do the test, we set up the test. Here we are going to set up the tubes depending on the panels that you have. For example, if you have 10 panels, then you're going to set up for each of the cells, for each of the panel, you're going to set up a tube for instant spin, a tube for 37 degrees centigrade, and a tube for AHG. When you have set up these 3 tubes for each of them, that means I'm going to have my if I have 30 panels, I'm going to set up my 30 tubes plus 3, because we also need to check to set up what you call an auto control, where you do the patient cells and patient serum. So that becomes our auto control. So that auto control is also key. So after we have set up our 33 tubes, then we react the antigen versus the antigen from the panel, that is the cell panel for each of them, with the serum from the patient that you have taken. So when you have done that, and then you now record your findings. So you do the instant spin for your first 11 tubes, you record. You do your, again, you do your reactivity test for at 37 degrees centigrade. Of course, we need to incubate for 15 minutes so that we can give the antibodies time to react. Then you record your findings. Then finally, you do the AHG, and then you record your findings. From there, on the AHG tube, you again do what you call introduce what you call check cells. Check cells are basically AHG sensitized cells or human antibody sensitized cells. These cells react with AHG. So when you have your AHG reaction in your test, you again expose these cells, especially the negative cells, to the check cells. Now, when you expose them to the check cells, it means now that you are going to control. So if there is a reaction, then you know it was a true AHG negative. If there is no reaction, then you know it was a false AHG reaction. So that is very important, okay, to have the check cells. From there, you check whether or not you have mixed phase reactivity. And that means if there's a mixed phase, for example, if you have IS reaction and AHG reaction, it means that there may be many antibodies in the same patient. From there, you make sure that the phase correlates with the antibody type that you know, the normal antibody type. And this is important because it also helps us to improve the diagnostic accuracy of our antibody identification. So that is step one, to confirm the reaction phase. Now, after you have confirmed the reaction phase, as I have said, you look for the pattern. Looking for the pattern means that if it reacted at IS, is it normally an IS reacting antibody? So if it is strongly positive, is it normally a strongly reactive antibody? If there is both weak reactivity and strong reactivity, so that you have, in one instance, you have a 2+ and the other one you have a 1+. Is there a dosage effect? Remember, we have antibodies, especially of the MNS, where M and N have dosage effect, S and S have dosage effect, and U and U also have dosage effect. So those antibodies, when they are occurring together, they have higher reactivity, but when they are occurring singly, they have lower reactivity. For example, if you have M, it will react stronger than when you have MN. If you have capital S and small s, the reactivity is going to be weaker than when you have homozygous capital S. So that is important in determining this, the variability of the reactivity when you're doing your antibody identification. Sometimes you have inconsistent reactions, and that will be because of antibodies that have affinity or have low affinity, or they are pH sensitive. So when you have such antibodies, then it means that you need to again either adhere to the pH changes or make sure that you use the correct amount of cells, that is cell concentrations or red cell concentration, to be able to come up with a good result of low affinity antibodies. Also, you have to give them time. And finally, when you look for the pattern, you also need to statistically confirm that the antibody identification. How? By making sure that there is a pattern of reactivity. Either at least 3 panels have reacted and 3 panels have not reacted, meaning where there was an antigen, there is a reaction. Where there is no antigen, there is no reaction. And we're going to see that as we go. And I've just said also that you are supposed to add check cells anytime you're doing your AHG. So for us to be able to make sure to understand that our HG is potent. It is important that you have sensitized cells. Now, these sensitized cells, you add to your negative AHD tubes and check whether or not their reaction. If there is a reaction, then you know that the AHG was okay, meaning the AHG reacts with the check cells, because remember, when you put a AHG and it doesn't react, it means there was no binding, there was no antibody. So when now you put check cells, which are already cells that are bound by antibody, and there's a reaction, then it means the AHG is actually okay. So that is the importance of having check cells. So whether you're doing a cross-match, whether you're doing a DAT, IAT, whether you're doing a screening, whether you're doing antibody identification, it is important for us to also consider adding the check cells in our day-to-day activities. Okay, so after we have done the pattern and it is there, we go back to our panel. Remember, this panel, when you acquire the panel of cells, you either make your chart or you can have the supplier can actually have made for you a chart. The chart is not marked, or you can make a chart that is not marked. So that chart is going to be something like that. And then we cross out. So ruling out the antigen that did not react means that when you have your panel of cells here, so this is the number of your panel, serial number, for example. This is the pattern of reactivity for each panel. So panel 1 has no D, but has capital C, no E, like that, all the way to the KID blood group system, where you have KID A is present, but KID B is not present. Then from there, now this here is our cell, our serum reactivity with these cells. So meaning, therefore, for panel 1, there was an instant spin reaction. For this case, panel 1, there was so you recorded a 2+ reaction. Then panel 2, there was no reaction. Panel 3, there was no reaction. Panel 4, there was again a 2+ reaction. Panel 5, panel 6, no reaction. Panel 7, there was another reaction. Panel 8, there's no reaction. Panel 9, there was a reaction, again 2+, then panel 10 all the way. And key to note, the patient typing here, the autocontrol, is also negative. So when that has happened, then it means now we are ready to rule out. So how do we rule out? We rule out by looking, is it vertical? Down the column to check where is the reaction on my left hand. Wherever there's a reaction, the panel that has a reaction, okay, we check what has reacted there. So for example, the panel 2, there was no reaction. It means in my serum here, from panel 2, the antigens that are present in panel 2, they are not reacting to any antibody in my serum. So panel 2 and 3, for example, there is no reaction, meaning any antigen in those two panels that did not show reaction means that antigen is not present, meaning therefore I can cross out. So I cross out D, I cross out C in panel 2, I cross out small e, I cross out P1, I cross out Lewis B, I cross out Celano, I cross out Duffy B, and I cross out Duffy A. Okay, so when I have crossed out, and make sure that when you're crossing out, it is very clear that you have ruled them out. So after I have done all that, so when I look at the row, I will not cross out antigens, on the rows that there was a reaction. So I'm only crossing out antigens on the rows where I did not get reaction with my serum. This is because those rows that did not react, I don't need them because those antigens are actually not there. I'm not interested in them because the antibody towards them is not present in the serum that I want to detect the antibody from. So that means, therefore, that we will be left with all those rows not marked. After that, we focus now on the antigens and we check down the column. Is there any place we have crossed? If you have crossed any, then you rule it out. So the antigen is not there. So from the top here, the cells here, you check down the column and see whether or not you marked. If you marked, then you rule it out. That antigen is not there. So you go all the way until you are going to be left with, if you look down a row, there you will find that there is no marking. Then you have crossed out all the rest. It means whatever is remaining is probably the antibody, the culprit antibody. And in this case, we are saying that we do not cross out antigen E and we not cross out the antigen Lewis A, meaning the most probable culprit in this reaction here in our serum is either Lewis A or the RH capital E. So from there, we have to go to the next step. So make sure that at least 3 antigen positive and 3 antigen negative panels are used. So if, for example, I have done that and I find that when I look across the row and find that, yes, I have 1, 2, 3, 4. So 4 panels actually had reactivity and the antigen are indeed not crossed. Then when I look at the one that have been crossed, the negative, 1, 2, 3, 4, 5, 6, 7, 8. So I know, I'm sure that I have at least 3 positive and 3 antigen. So I can go to the next phase or at the next step. Okay, now, so before we do that, then we need to know the antibody history of the patient. Key to this, we have to understand that these blood group system antibodies are very, very important, especially in HDN and hemolytic disease or transfusion reaction. Now, we need to understand that IgG anti-KEL and IgG anti-M actually react or bind to epitopes on the precursor cells, on the progenitor and precursor cells of the blood cells. Meaning, therefore, if we make the mistake of giving this blood anti-KEL, then chances are that if it was a fetus and the anti-KEL is positive, then it reacts with precursors or progenitors. When it reacts with those progenitor cells, it means that the development of the fetus is impaired at that time. Meaning at the onset of hemopoiesis, that is where the anti-KEL and anti-M IgG act. What does that mean? It means that this, if then it was a lady whom we gave blood and they developed anti-KEL, and that anti-KEL, now she gives, she plans to have a baby, then that anti-KEL, if it is IgG, it will react with the baby's cells and the fetus may not develop. And therefore, there will be a miscarriage. On the other hand, IgG, anti-RH, and anti-Daffy and others act on the mature RBCs, meaning therefore when the red cells are maturing at about week 28 onwards to birth, at that time, then that is when our, especially RH, IgG, RH anti-D, anti-C, anti-G, all those will react on the mature blood cells. Meaning, therefore, at that time is when now there will be the HDN. So at week 28, if it is severe, then we know, of course, that the other concepts of HDN, where we have severe HDN, where now the baby can be born, but either severely jaundiced, icterus gravis neonatorum, or dead. So that is important. So we need to understand and appreciate that when we are doing our antibody identification from the mother, we are trying to see how best can we help the fetus, and this is key. So it is important to review that and then consider also autoimmune diseases that will affect RBC testing. We also need to check for past either HTR or hemolytic disease of the newborn. Now, we must always correlate our finding of the antibody identification with the patient's current true serological picture. That is very important. So after we have checked the patient history, then now we exclude the autoantibodies. Now, exclusion of autoantibodies is important where we have the autocontrol, which distinguishes between autoantibodies and alloantibody. So it is important for us to set up both a cold autocontrol and a warm autocontrol. Remember, autocontrol panel with panel reactivity, if an autocontrol is negative, like we have here, and we have the panel has reacted as we had in the past slide, then that is a true alloantibody. But if the autocontrol is positive, the direct antiglobulin test is positive, then chances are we may have an autoantibody. And if you do this at 4 degrees, 0 to 4 degrees centigrade, and incubate this, then you might be having your autoantibody, cold autoantibody. So this is important for interpretation and continuous. So if you have antibodies, then this definitely will complicate our interpretation because we may need to now check which autoantibody is this. And sometimes the fact that there is an autoantibody will mask the presence of an alloantibody. So we have to again do the autoantibody test, remove the autoantibody from the picture, and try to again do the antibody identification again. So this is important. Okay. Okay. So now, so from there, it is important for us to phenotype, but phenotyping the patients usually is important only when the patient has not been transfused, especially in the last 3 months. So most we do is we phenotype and we cross-match and give. However, if a patient has been transfused in the last 3 months, it is important for us to check, especially if the screening is positive. It is important for us to check whether or not there are antibodies. From there, now we can do the antibody identification and probably also do antibody identification or the antigen specificity of the donor cells so that we can be able to give as much as possible or as far as possible patient-specific donor cells. This is key. So other than that, we will probably need, as we proceed, we go on, probably need to do molecular genotyping, which is especially useful currently in SCD, where we have continuous giving of the blood. So we need to really check on that. or in oncology, again, in oncology patients, we also do a lot of transfusion. So it is important for us to genotype in these areas. So the genotyping will now detect other blood group variants. For example, sometimes you may have a blood group A patient who is constantly rejecting A blood. So in that case, you need to actually genotype to see which type of A probably is this person, so that we now give A specific, because remember, anti-A can actually react with most of the A's. So it's in this regard, therefore, this patient has made anti-A. Now, so we need to know specifically if it is A2, A3, or any other of the A's, then we can now again go to the blood bank and see whether or not we can, or we call out to see whether or not we can have donor cells that actually have blood group A specific to our patient. So with this, then we can say that phenotyping, also genotyping, and antibody identification will strengthen the need to provide extended matched units. So in our setup, we have not done extended matching, and it is critical because now it affects patients and the patient well-being is actually not monitored to the best of. We don't give the best care because we do not actually do extended matching. So even when there is a transfusion reaction, we do not do extended matching. Even when there's a transfusion reaction, most of the time we do not do antibody identification so that you can give the best blood. We just go blindly and do another cross-match and another cross-match and another cross-match. And yet what we should do is actually do antibody identification. Then after that, we can now specifically take the cells that actually do not have the culprit antibody. Okay, so from there, we need to select the antigen negative units, okay, and then we match them to the patient. And this is important so that we also confirm the donor antigen type with appropriate antisera. Okay, so IAT cross-match is usually required, and it is important to always document. Documentation of least incompatible units is essential. So anytime you're doing your cross-match and you have, then you find antibodies, ideally you're supposed to now again do antibody identification. After selecting the antigen negative unit, then you can now give that blood to this patient. Now, how do we resolve multiple antibodies in our panel? So you have done your panel of cells, you've done and you found that you actually have mixed reaction. So the first thing is you perform a rule out sequentially as we have done in the other slide. Then from there, you look at the strong reactions. From there, you select the cells lacking cross-reactive antigens. Then from there, you can either use enzyme panels now. So you take out the selected cells which are lacking cross-reacting antigens and the ones that have cross-reacting, and we do enzyme panels, so enzyme-treated cells, to now do check whether or not the overlapping patterns can actually be resolved. So we know that there are antigens which are reactive only when the cells, or antibodies which are reactive only when the cells have been enzyme treated. Okay. Other than that, we can absorb the antibodies, especially in pan-reactivity. So, for example, if you have D and Lewis A, and you are not being able to rule them out, so what you do, you put your D cells, and the D cells will absorb, and when the D cells have absorbed the antibodies, and probably the E cells have also absorbed the antibodies, and then now you test your D cells to find out whether the antibodies are actually absorbed or not. And this probably you can do using your elution techniques. So it is important to note that as you are resolving your multiple antibody techniques or multiple antibody presences, you need to look at, first of all, the IgG significant antibodies first. Remember, the patient is waiting. So when the patient is waiting, it is important that you do the IgG, clinically significant IgG first before you do the others, because these IgG the IgG are usually the most clinically significant, and from literature, then you need to understand which of these are much more significant. As I've mentioned there, you have anti-C, you have anti-KEL, and you have anti-M. These are clinically significant IgG that may affect adversely either HTR or even hemolytic disease of the new fetus or infant. So in that case, then when you have resolved that, you can now give the blood as necessary. Okay, so in doing all this, sometimes you have your mixed reactions. And mixed reactions are very, very, make our antibody identification complex. So first of all, mixed reaction can be as a result of mixed antibodies. Second of all, mixed reactivity can be as a result of dosage effect. So sometimes you have two antibodies. For example, in the panel that we are having here, you have reactivity in panel 1, reactivity in panel 2, reactivity in panel 3, panel 4. Now, if you look carefully, you'll find that there is reactivity in panel 4 at 2+ in 37 degrees centigrade. So first of all, we have to say that here we are expecting mixed complete antibodies and incomplete antibodies, meaning IgG and IgM, most probably. So when that is happening, so the most crucial here is that we have the 37 degrees centigrade reactivity. So we have 37 degrees centigrade reactivity in panel 1 at 1+, panel 2 at 1+, but panel 4 at 2+. So meaning, therefore, that if you check closely, you find if you now have that, what happens is that when you have homozygous dosage effect, the antibody or the antigen is occurring homozygous, then it means that the other allele or the one that is causing dosage is not there. So if you look across the panel, for example, and this is just an example, the dosage effect, the cells that are culprit for dosage effect include RHE, RHC, CEC. So the C and the capital C and the small c, capital E and the small c actually have dosage. Then we have MN and MNS. So MN have dosage effect. So when you find that there is reactivity 2+ here, it means the culprit antibody is occurring exclusive from the one that is usually normally causes dosage. Okay, so when you're going to now rule out, you're going to find that indeed the antibody here could be, for example, Daffy B. So when you find out like that, because for example, when you look at panel 4, Daffy B is occurring on its own. When you look at panel 1, which is 1+, Daffy A and Daffy B are occurring together, meaning the reactivity with either of them would be impaired by each other so that there is dosage effect. So the dose for Daffy A is reduced when Daffy B is occurring, and vice versa. But when now Daffy B is occurring alone, it expresses fully, and therefore probably the antibody reactivity is much stronger. So that is how you check for dosage effect. So these dosage patterns will therefore support or eliminate the possibilities. So that is how we have now eliminated that possibility of Daffy in that. So yeah, so now from there, we also look at the warm autoantibodies. It is important to also understand when you have warm autoantibodies reactivity in your panel, that you can actually resolve the warm autoantibodies by either autoabsorption or alloadsorption techniques. And it is important that when you have patients who have warm autoimmune hemolytic anemia, it is important that we select carefully the compatible blood, because if you get antibodies, or if you get cells that the patient may be reacting to, then you have an emergency on your side, because when remember, you're giving blood when it is cold or cool. So as the blood is entering the patient, they may not react. But immediately the blood has, actually sometimes when the whole of the unit has been transfused, then you find that there is reactivity and massive reactivity at that. So it is crucial to make sure that you select carefully compatible blood when you are doing compatibility or cross-match for warm autoimmune hemolytic anemia patients. Cold autoimmune or cold autoantibodies usually react strongly at IS, and it is important to note that some antibodies such as MNS blood group system antibodies have what we call high reactivity amplitude, meaning, or temperature amplitude, meaning some of them react even at all the way up to 30 degrees centigrade. They are cold antibodies, but they react even at 30 degrees centigrade. So these antibodies are crucial, especially in when you have cold autoimmune disease. So cold agglutinin syndrome will show broad thermal ranges, and these usually occur if it is autoantibodies. They usually occur especially with blood group system I capital and I small. So this is very important. So we need to prove that the antibody is not a cold antibody. So for us to be able to detect, because this react at IS, so for us to be able to detect that, we can pre-warm the antibody so that we remove the cold autoantibody interference. So when you're doing, anytime you're doing your antibody identification or even cross-match or otherwise, if you do an instant spin and you suspect that there is cold autoantibody, you pre-warm your reactants so that you do away with the cold autoantibodies that can affect your reactivity pattern. So the common clinically significant antibodies that you will detect using your antibody identification techniques. The common clinically significant ones include, in the Rh blood group system, we have the D, capital C, capital E, and E, where this is actually the group of antibodies with the highest ratio of HTR, that is hemolytic transfusion reaction, or hemolytic disease of the fetus and newborn potential. So it means that when you have Rh blood group system, antibodies D, C, capital E and D, and capital E, you are going to have, these are the culprits normally in HTR or in HDNF. Now, the others include KEL. KEL blood group system antibodies are actually very immunogenic and show or come up with severe risk of hemolytic disease of the fetus, especially of the fetus. So it is essential for us to know that when we are doing our cross matches, that is the initial phase where we have this, and we have positive screens for antibody, we have to deal carefully with whenever possible when you have KEL reactivity. Okay, then we have keyed blood group systems. These show weak reactions, especially they cause delay. So after 14 days, a patient comes back, they have delayed HTR. Then Duffy have association with malaria, and MNS, the most important are S, and U, capital S, small s, and U. These antibodies also have high, because they are IgM, but they have high amplitude of agglutination, including up to 30 degrees centigrade, meaning that they may actually cause HTR in that case. So finally, a case walkthrough. I know LMSK may share these slides. When they share these slides, do the stepwise panel reading, rule out, rule in, handle the mixed warm cold interference, try to come up with a final identification unit and cross-match result, and then a sample reporting whereby this panel can actually take you through. And if you are able to do that and make sure that you get a reaction and the type of warm because this is warm, so the type of warm antibody that could have been the result in this case, then you are good to go. So with that, I am really grateful and I thank you. Thank you very much. Arthur?
Daktari, thank you so much for such a wonderful presentation. It was quite very, very, very wonderful. And I'm sure many of us have enjoyed. And also it acted as a refresher. I know many of us maybe went through some of these details long time ago, but now I think Daktari has done it in a very clear way, and it was quite insightful. I can read all your comments here, and I can see many of you saying it was quite interesting. And at this point, Doc, we just want to pick a few questions that might have arisen from this presentation. And if you have any questions, or if you feel you can make a comment, you can always raise your hand. We shall be able to unmute you, and you shall be able to make your comments. Otherwise, if you have a question also, you can still go to the chat box and just type in your question, and we shall be able to read it together. Otherwise, I can see many of you are really applauding the speaker for a job well done. Rafael Kingori saying wonderful presentation. Fatim Mohammed saying good presentation. And many, many, many of you. So is there any question from the presentation that has been done, or any comments? You can just come to the chat box and just type in your question, or you can unmute. You can raise your hand and then you shall unmute and maybe ask your question. Otherwise, we continue to receive your feedback. Moses Oduri is saying, nice presentation, my lecturer, Mr. Wigina. And then Lillian Ouma is asking, we share the notes. Sure, Lillian, we shall share the notes. And this session is also live on YouTube. You can always go to YouTube at Lab Medicine Society of Kenya and look for this session. It is being broadcasted live. So you can always go back there in case you want any reference. So someone here is asking me about the CPD session for the last webinar. I think they've all been uploaded. And in case you have any challenge, kindly you can always reach out to us through the phone numbers that you can see on the posters or through our email. We shall be able to respond. So is there any question from the presentation? If you feel you want to make a verbal presentation, you can just raise your hand and I shall be able to unmute you, and you shall be able to speak. So I can see Tom Were. I'm not sure that this is Dr. Tom, but Tom Were is asking, can you comment on pregnancy sensitization in regards to monogamous versus polygamous unions? Thank you, Tom. Again, I don't know whether this is Dr. Tom, but if he's the one, thank you for tuning in, and we welcome your comment and your question. Daktari, did you get that?
Yes, Daktari is asking a very intriguing question. Monogamous versus polygamous unions. Sensitization, wow. I'm not seeing how, unless, and this is something that I have always talked about and said that during the blood transfusion, or sorry, blood donation, it is very important for us to understand that giving your spouse blood is a no-no. And it is also important to understand that giving it is important that we try as much as possible to not give our siblings, because we have the likelihood of having those antigens or antibodies. And now that exacerbates the situation where you have a lot of reactions that were not supposed to be, or sensitizations that are not supposed to be. So it is critical that at least we move away from that. So as for monogamous and polygamous unions, I'm not seeing how that union is going to affect or impact on sensitization. Thank you.
Thank you so much, Daktari. Sure, this is Professor Tom Were. Prof, thank you for the question and thank you for tuning in. I think I missed this, but welcome. Unless you have any insights, Prof, you can unmute and maybe comment. I have given you the rights.
Yes, I would really have to wish to hear from. Afternoon, Prof.
What I'm asking is a bit complicated.
It is.
We all know that, and I'm sorry to say this, a number of young ladies may have abortions, probably from one male or several males, then later they get married. Then, of course, let's say the husband dies and the lady is inherited with another husband. So what I meant was the exposure to those multiple antigens with regards to the different male partners. Would that increase the likelihood of multiple sensitization? Probably is a bit complex. We can do some research and think about it.
Okay, Prof, that one is not complex. That one is a yes. Because all of us, we know that the red blood cell especially has multiple antigens on its surface. So as you get the baby is formed, especially during either birth or during the abortion, there is a tendency for the cells to cross the placenta. So when the cells, even if it's a small amount of cells that cross the placenta, they always impact on the antibody formation in the female. And that is critical for the next and the next and the next. So if you have more partners, the more partners you have, of course, the more likelihood you are sensitized, and therefore the more likelihood that when you now get a viable pregnancy, the chances of probably you again affecting that child, or when you have one that now you want, because this was probably abortion, now you get what you want, then it means therefore that could happen. Now, inheritance, again, because of the fact that the first person had or could have similar sensitizing antigens as the next one, if they are inherited as kin, then again, that also, for example, if the lady is RHD negative and the husband is RHD or even blood group O, the lady is blood group O, the likely, and the first husband is blood group A, or let's say B for this matter. So it is likely that the brother to this person is also blood group B. So anytime she gets pregnant, then the chances or the likelihood is that she gets a baby who is blood group B. So the likelihood of this baby, because of the multiple times that she had pregnancy, the likelihood of the mother to develop immune and IgG anti-B is increased. When that happens, then the likelihood of this baby suffering mild to moderate HDN ABO is also increased. So that is something that we can say like that. So I think it is true, Prof, what you're saying, and I think that is how we can view it. Thank you.
Thank you so much, Prof, and Wigina for that insightful response. I'm sure we have all learned something, and there are more questions. And maybe at this point, you allow me to pick the next question from Biko Omondi. And Biko is asking, is it right to conclude that these antibodies are responsible for rare or few hemolytic reactions resulting from transfusions, even in well cross-matched blood? Doc, if you had me.
Yes. Cross-match is only a cross-match is only viable at the time of cross-match. Anything away or outside of the cross-matching time is not subject to the cross-match that you have done. So it means, therefore, that the moment you have cross-matched, okay, and the cross-match is compatible, then you give out that blood. Remember, you did not detect the patient's ability to develop antigens against the blood that you have given them. So meaning, therefore, when you give them this blood, they could actually have a transfusion reaction, a mild transfusion reaction, or they may develop antibodies, so that when you give them next blood, they can be actually incompatible at that time. And also remember that delayed transfusion reaction occurs when now it takes about 72 hours to develop the antibody. So when that happens, then within those 72 hours, the blood that you are transfused can now again start to react. The patient themselves start to react to this blood as a result of development of the antibodies. So gradually these are destroyed. So the red blood cells that you give will actually be destroyed gradually. So those are delayed transfusion reactions. So yes, antibodies, blood group system antibodies actually are the culprits in the reaction that we have. And the most challenging thing is that we do not follow up as laboratorians. Arthur?
Thank you so much for that. It's quite insightful. Maybe we can move to the next. That is, this is from Elvis Otiende. How can panels be standardized globally considering the variations in antigen frequencies across different patient populations and ethnic backgrounds?
Thank you, Elvis. You don't standardize populations, so you make your own. So it's important for us to know that the reactive, for example, we have noticed that around the Congo Basin and these sub-Saharan, JSA and JSB are critical in the MNS. So again, you're only going to do that. You can't go to Europe and do that. So in the end, whatever you have here, we have here, it is us to make sure that we do proper research to know which are the culprit antibodies in our setup. With that, then we develop or standardize our own panels. You notice that even in the coastal region versus the western region, we can still have that type difference or variation. So it is critical that wherever you are able to do that. And that's why probably we have regional centers, so that those regional centers can actually help us to determine the most common antibodies around that area. So we don't standardize globally, but we locally make, or we locally know what we need. We locally justify. Arthur?
Thank you, Doc, for that. This is Job Onunga. Thank you, Job. And Job is asking, I think there was a slide, and he's asking, is there any relation in terms of conceiving between a person? Not really, not really. So he's asking, when the panel shows weak reaction at IS only, which is the most likely antibody? Thank you, Job.
Arthur, I will tell Job to do to follow the steps of the panel so that he finds out which is the most likely antibody. However, of course, we must go back to the book. We must go back to the literature and see which are the most common IS or IgM antibodies within our population. So we cannot say exactly which is the most likely. And thank you, Job, my friend and student, for tuning in.
Wonderful, wonderful. Okay, so this is another question from Benson Kangede. And Benson is asking, is there any relation in terms of conceiving between a person of blood group A and O positive?
Repeat that question, please.
Is there any relation in terms of conceiving between a person of blood group A rhesus positive and O rhesus positive?
I think the question is not framed properly because what relation in terms of conception is this? Because I think he could write it again so that or he could just talk so that we understand exactly what he wants us to answer. Arthur?
Thank you. I think we have come to the very end of the questions that we had. And thank you so much for the insightful presentation, Wigina. And you can see from the chat box, many were tuned in and many are really impressed. And I'm sure this will change the practice. And I'm glad with the opening remarks you had, so that these sessions can actually impact us positively. Otherwise, I'll take this back to you for your closing remarks.
Thank you, Arthur. And I must say that I'm privileged to present, and I'm hoping that our people can actually be able to understand and appreciate the extent of our profession. Our profession is wide, and we need not fear that there is automation. But what we need to do is expand beyond our current borders. It is hurtful to note that most of us are just blocked into the tiny spaces that we are in. And with automation coming, those tiny spaces are now being exposed. So it is important for us to understand that we can actually do much, much, much more. And this is one of the areas where we can actually do more, whereby we need to make sure that all our cross matches, all our blood grouping is up to task and up to date. So with all that, I kindly ask for us to try our level best to make sure that we embrace these other technologies, other tests, so that when we are doing the test, we are actually able to help the patient as best as possible, give the best patient care possible. And us being the eye of the profession, we are going to go far. Thank you, and thank you very much.
Thank you so much. And I want to thank everyone who found time to join in. On behalf of LMSK, we want to say thank you and see you next time. Thank you so much.